O vídeo passa você ou passa eu, Vianello?
Passo eu, tá aqui comigo.
Tá bom, beleza.
Vai abrir o YouTube já, só um instante.
O vídeo passa você ou passa eu, Vianello?
Passo eu, tá aqui comigo.
Tá bom, beleza. Era reprise.
Vai abrir o YouTube já, só um instante. Bom, boa tarde a todos. Nós estamos também ao vivo no nosso canal Glaucoma Zoom no YouTube.
Passo eu, aqui, tá bom. Você tem que desligar o som do YouTube aí.
Boa tarde a todos. Nós estamos aqui ao vivo no Glaucoma Zoom, também no canal do YouTube. O Glaucoma Zoom é uma iniciativa de 3 serviços de oftalmologia de Belo Horizonte, o Centro Oftalmológico de Minas Gerais, o Hospital São Geraldo da UFMG e o Instituto de Olhos, Ciências, Médicas. Hoje nós teremos a honra de receber o Dr. Malik Kahook, né, inventor do Kahook Dual Blade, e vai nos explicar aí tanto a técnica quanto todo o seu know-how, expertise. Temos como moderadores o Dr. Fábio, que é o chefe do Instituto de Olhos e Ciências Médicas, e o Dr. Tiago Prata, que é o chefe do nosso departamento de glaucoma em São Paulo. Então, nós vamos ver agora um vídeo de um dos nossos patrocinadores, aos quais nós gostaríamos de agradecer, a Ofta Vision Health, a Allergan, a Latinofarma e a Glaukos. Após o vídeo, o Dr. Fábio introduz o Dr. Malik, ok? Fábio.
Você compartilha sua tela para a gente, Marcos? Boa tarde, pessoal, tudo bem? Hoje a gente vai abordar um tema bem interessante para todos nós, com o Dr. Malik Kahook, e fiquem à vontade para fazerem as perguntas que julgarem necessárias no chat, que depois a gente vai passar o que for possível em conjunto para que ele possa responder para a gente. Dear Dr. Malik, thank you so much. It's truly a great pleasure to have you here. On this Saturday will be an outstanding moment for us, for sure. So we do believe that this is a unique opportunity for us in Brazil to share the experience of the KDB and trabecular minimal invasive surgeries. And we would like to introduce you to our people, our friends. This is nothing more, nothing less than the person or the one who gave the name for the KDB procedure. So he is a professor and vice chair of the Department of Ophthalmology and chief of glaucoma service at the University of Colorado. So thank you for coming and sharing your knowledge with us. Thank you so much, Dr. Kahook.
Yep, thanks for having me. I'm going to go ahead and share my screen here and look forward to spending time and going through a few slides. Hopefully you can see my slides already now that I've shared them. Let me know if there's any issue with the connection. I see this is very informal because a lot of the audience and certainly, a lot of the faces that I'm seeing on the screen are very experienced when it comes to glaucoma surgery. So this is a little bit different than what some of the talks are by Zoom, where we're going through a lot of the basics of angle surgery. I'm not going to do that as much. I might spend a couple of slides just going over some of the pearls that I use to educate those who might not be doing as much angle surgery. And it'll be interesting to see what you guys are doing that might enrich a little bit more of how I'm doing things. So I'm going to go ahead and advance the slide here and get into some of the basics. What I wanted to start off with are a couple of slides that I think are going to be familiar to most of you. This is the slide that I used to think of when I was a fellow. So I did fellowship. I was finished with fellowship in 2006. So I've been out for about 14 years now. But this is still what I was talking about when I was in fellowship. It was medication followed by laser, followed by trabeculectomy. And it was also at the stage where we weren't doing very many primary tubes, right? So a trab or two trabs would fail, and then you would move on to a Barvelt or an Ahmed device. Now the story is completely different. Now we have a middle ground here between medication, laser, trabeculectomy, and tubes, this green arrow coming down, where we have all of these angle procedures. And different markets around the world have access to different devices. I think most people have access to goniotomy around the world, but you also have a lot of these devices that are trabecular bypass devices like the iStent. In the US and other markets, we also have Hydrus. But all of these devices are really changing the way that we're going about treating our patients. We don't always go in this orderly fashion that we used to go in. And I think that's adding a lot of benefit to our patients. The topic today is about goniotomy. And goniotomy used to be a topic that we only discussed with congenital or pediatric glaucomas. And that's certainly not the case anymore. We know historically that Barkan gets a lot of credit for what we think of as the modern day goniotomy, where there's a gonioscopic lens and we're doing things ab interno. But goniotomy was done in many different forms, even before Barkan. There were different methods for doing it. Unfortunately, around the time that goniotomy was introduced, there was this thought process that it only worked for kids, because the adults that were treated with goniotomy always had a fusion of their leaflets and elevation of pressure. So there was this thought that it only works on kids where there's more retraction of the trabecular meshwork. And for decades, really, we didn't see very much done with goniotomy. Now, there were certain countries around the world that were doing goniotomy with different devices, but it didn't really catch on until really just a couple of decades ago. And this is really the history of the device that I'm talking about. This is a device that was born out of my laboratory and picked up by New World Medical for commercialization. I always like to give a little bit of background just to give people an idea of where this device came from. My laboratory at the University of Colorado is focused on many different projects. One of them is imaging with femtosecond lasers. And I'll just maybe draw a couple of things here so you can see. Over here, you see trabecular meshwork nuclei using a specific type of femtosecond laser imaging. These are pigment granules. And then, of course, you see the beams and the trabecular meshwork cells with great ability to distinguish the cells. And of course, the goal is always to bring these into clinic. But before doing any of this, we had to get whole strips of trabecular meshwork. And for the imaging studies, we had great difficulty in getting a strip of trabecular meshwork. We were getting, because it acts like wet tissue paper, we were getting little bits and pieces. And it really wasn't good enough for what we were intending to do. And because of that, I took a step back and I started working in our device lab to make a device that would truly excise a strip of trabecular meshwork, fully intending for it to be part of our imaging studies. And I worked with various devices. I worked with needles. I worked with some of the goniotomy knives that are in the market, some of the historical ones where you can look up old papers and see what the design was. I was never able to get the parallel incisions that would allow for creation of a strip of trabecular meshwork until we added a ramp that I'll go over here on the next slide. And that ramp turned out to be the key feature for excising a strip of trabecular meshwork. To place it on stretch before the actual cutting takes place was a major point. When we got to the end of the project and we made this device and we were getting strips of trabecular meshwork for imaging, that's when we said, wait a second, this could actually be something that we would use in the operating room. And that's how the journey started towards KDB. Now, I did mention the ramp here, and I think I want to draw on the slide here. Hopefully you guys can see this a little bit more. I'll switch the color to black so you can see it a little bit better. The tip of the device was designed so that it could go into the trabecular meshwork, but no cutting, no incision would take place until the trabecular meshwork goes up the ramp. So the blades are actually positioned above the plane of the trabecular meshwork. Once the TM travels over the ramp and is, if you will, goes from this plane to being stretched over the ramp, that's when the cuts take place. And it turns out that's the key, to get the right dimensions, to have the blades separated apart the right amount. And that took multiple iterations to get to. We started doing some of the basic science around this to show that there's a difference between incisional and excisional. This is a basic MVR blade, which is typically how congenital goniotomy or pediatric cases are done. Unfortunately, there's often damage to the underlying sclera, not just to the trabecular meshwork, and these leaflets remain. So these leaflets in adult patients will eventually fuse. And the goal was to take as much of the trabecular meshwork as possible away. And that's what we were able to show for KDB, looking at KDB versus MVR versus other devices. We're able to remove this entirety of the trabecular meshwork from the scleral spur all the way over to the Schwalbe's line area where the TM is more adherent. That gave us great confidence to take it to the next step and take it into the operating room, where we worked with New World Medical to get it through the regulatory lines that we needed to get through in order to get it onto various markets. Now, I wanted to show one of the cases. This is John Berdahl operating, one of my friends who did one of the first cases when this was first launched, and an experienced angle surgeon. And you can see he goes in, this is either his first or second case, and this will loop so you'll be able to see the case again. This is one of the initial ways that we started doing the procedure, was to go from the outside in, and to do that in a way that allowed for creation of a strip of trabecular meshwork that could then be removed with microforceps, which is what you see happening over here. And then you see the collector channels, which are leaking into the anterior chamber, which is exactly what you want to see. Now, that's an experienced surgeon who's doing, maybe their number 2,000 or 3,000 angle surgery. And I think one of the keys here is that even if you're not as experienced in the angle, this is one of the safer things to start off with. Now, this is Paul Singh, who, again, another experienced surgeon, who is showing something that I wanted to point out from a beginner standpoint when it comes to angle surgery. Now, of course, he's not a beginner, and he's able to show a couple of points. I'll see if I can point it out when he starts with the procedure here in a little bit. You'll notice that when he goes in, he actually angles I'll reverse here and then play it one more time. He actually angles his tip up. You see that right there? So it's about 10, 15 degrees up when you're going into the canal. That really facilitates the procedure itself, so that you can get in. Once the tip is in the canal, then you even out. You put the heel against the sclera and you march along. These are little subtle points that you can find more of the educational videos that are on the internet. If you haven't done one of these procedures before, it's a little bit different than if you're doing an eye stent or some of the other procedures that you might be doing. The positioning is certainly different. Now, one of the things that we can talk about maybe during the question and answer session is what a fluid wave looks like. And this is something that I do on every single patient, whether it's through irrigation aspiration, where I'm looking to see what vessels are blanching, or if I do it with an AC cannula, as you're seeing over here. This is my partner, Leo Seibold, doing this. And you can see superiorly here, all of these vessels right over here are blanching. And I usually tell the patient afterwards that, that sign that we talked about before surgery, where I wanted to see patency, where it's going to the distal outflow system, we saw that in your case, and we're excited about that. I wanted to see if I can play the other video here, which is Fabio's case here. There you go. It's a little bit obstructed by one of the screens on my computer, but hopefully you can see it. This is a video that Fabio sent me where I'm looping it over and over again so you can see exactly what's happening with the vessel that's right in the middle of your screen. These are great things that you can use to make sure that your procedure was successful. And again, I do it on every patient. Now, keeping in mind the audience that I'm speaking to today, I wanted to think of a few things that I could share with you, knowing that many of you know the basics of angle surgery. What are some of the pearls that I like to at least discuss or debate with some of my colleagues? And one of them is how do you get people started with angle surgery? A lot of times with experienced surgeons, we just go in and we do the procedure, and we don't always take the time to train or to maybe even go to the wet lab and practice. With angle surgery, I think one of the major benefits that we have is that most of us, if not all of us, are cataract surgeons. So when we're done with cataract surgery, and if we haven't started as an angle surgeon, we can always practice at the end of cataract surgery by tilting the patient's head, tilting the microscope, and just taking a chopper, as you see here, and doing that motion, that side-to-side motion that isn't typical for what we do with traditional glaucoma surgery or traditional cataract surgery. And do this for 10 patients in a row. So when you're training residents or fellows, or if you're just getting started, if you haven't gotten started with angle surgery, this is something you can do to get comfortable with the positioning where your hands go, where the gonioscopic lens goes, and then again, that motion that's side to side, that's not very typical for traditional surgery. I found this very beneficial. It's also helpful for fellows who come in who maybe didn't have the angle experience during their residency. Now, here's another point that I don't think gets as much attention that is one of the most important things about doing angle surgery, and that is making sure to construct the proper wound, which is slightly different than what we do with traditional cataract surgery alone. A lot of times with cataract surgery, when we're going in to do the clear corneal wound, we try and cheat a little bit, so we're catching some of the perilimbal vessels. So there's a slight ooze, and there's a thought that that might actually help with sealing of the wound and healing post-operatively. With angle surgery, we'd like to avoid that because that oozing of the blood that happens, even if it's very subtle, can get into the viscoelastic and really obstruct the view when we're trying to do angle surgery. So one of the primary things that trainees can do, or somebody who's new to angle surgery, is to make sure that you go a little bit more anterior with your clear corneal incision so you don't get the oozing from the vessels that can obstruct your view. So that's another pearl I think that is worth teaching others when you're teaching others on how to do angle surgery. And then here's another one that became a very, very common question when we first started doing angle surgery. And it might be something we can discuss here towards the end of this talk. Do you do your angle procedure before the cataract surgery or after the cataract surgery? And in my case, I always did it after the cataract surgery. That's the way that I was trained. It was the way that I was most comfortable. Take the cataract out, put the lens in, take a breath, say, okay, that part's over with. Let me move on to positioning the patient. But a lot of surgeons prefer to do it before because the feeling there is that you might not have as much corneal manipulation. Your view might be better. And the truth is, nobody had data to show one way or another if it was better one way or another. So we actually ended up doing the study here, and you can see several of my colleagues on the paper that we published in 2019. And it turns out there really is no difference. Whether you do the gonioscopic visualization before or after cataract surgery, we put the photos in front of multiple experts. We asked them to grade which view was better before or after, and we found essentially no difference. So you can choose to do it before or after. And now we have some data to help validate that response when we get asked the question. And then this last point for the pearls before moving on to the next section is about visualization in patients who might be lightly pigmented. So one of the biggest struggles that we have, especially when somebody's first starting out with angle surgery, is to get that proper view of the anatomy. Where's Schwalbe's line? Where's the iris? Can we see scleral spur? And in Colorado, we have a very large group of Caucasian patients who have lightly pigmented trabecular meshwork. And the one thing that I always like to mention in talks is the use of trypan. I'd actually be interested to see if you have access to, the trypans that we have access to. You might actually have access to more than we do. But we use this routinely with cataract surgery, and certainly the same technique that you use for cataract surgery, you can use for painting the trabecular meshwork. You would put it in just like you would pre-cataract surgery. You can then wash it out. You can go about your cataract surgery if you like to do that initially. By the time it's ready for gonioscopy and you're tilting the patient, you see this nice blue line here that gives you, essentially, it's kind of like landing a plane. You know exactly where you need to go with whether you're putting in an eye stent, a hydrus, doing any of the other devices that you might be using, or doing goniotomy like we do with KDB. You have this pathway, especially for the novice surgeon, that gives you some comfort. If you haven't done this before, I would encourage you to at least try it, because there will be some cases where you're going to need it. Now, from a Pearl standpoint, it's always good to talk about who's a good candidate and who's not a good candidate. When it comes to goniotomy, especially when you're doing your first few cases, it's really good to have a cooperative patient. Now, we can say that about any procedure that we're doing. This isn't unique to goniotomy. We need a good view. We need to know that we have a good view of the nasal trabecular meshwork before we go into the operating room. So it's very important to get comfortable and to do gonioscopy. Certainly the crowd today, that's listening in, I would say almost everybody is going to be extremely comfortable with gonioscopy, but not everybody is. And when some of the general ophthalmologists are doing angle surgery, some of them are just not as comfortable doing gonioscopy. So that's part of the practicing that I mentioned earlier. And then any stage glaucoma, which is a little bit different than what we're used to talking about with angle surgery, whether it's mild all the way to severe and end stage, those would be candidates for goniotomy. And I'll go over some of the data to show why that's the case, as opposed to some of the other mild to moderate devices that we've talked about. Now, who isn't a candidate? What are the contraindications maybe in certain patients? Anybody with active neovascular glaucoma, we want to avoid those patients. Certainly you can get into trouble by going through the fibrovascular bundles and causing bleeding. Anybody who's an active uveitic, I usually try and stay away from all of these angle procedures. And I would try and do a tube instead, whether it's an FP8 or an FP7, doing an OMED in those cases. If you don't see the angle, don't do the surgery. So if this is a common thing in all of medicine, if you can't see it, don't touch it, don't treat it, don't try and do it when you don't have a good view. So always be sure that you can do gonioscopy. And then if the goal is 10 or under, something that you might usually get with a trabeculectomy, then it's not a good idea to try and do angle surgery for those patients, because you're typically not going to get as low as 10. So you can reserve that for a trabeculectomy, a Zen, Express, anything that you might do with a lower pressure that would be possible. I wanted to touch on some of the studies here, so you get an idea of where the data might be coming from. We've been able in our center to publish multiple studies, and other centers have published multiple studies, and I'm just going to present a snapshot of those. The first study here is actually one of the first studies that was planned by New World. Cyril Duraraj out of Mayo in Jacksonville was the lead author on the 12-month study. This is looking at only open angle glaucoma patients. This was a prospective study, 7 centers. And what I really like about this study is they actually divvied it up between higher and lower IOP. There was a 6-month study that you can see up here. This is by Mike Greenwood, who was the lead author on that. But the data that I'm showing you is for the 12-month study. And what they found out here, to me, is very interesting. They took the data and they split it into high baseline pressure, the mean baseline pressure, and then low pressure. So you see that here at 20.5, 16.8 for the mean of the two groups, and then 13.1 for low pressure. And no matter where you started, it still got you around that 12 millimeters of mercury at the last follow-up. So this to me is very telling that if you take away the trabecular meshwork for about 4 o'clock hours, you're going, in a significant amount of the patients, you're going to get a low pressure that is equivalent to what we would expect when you remove the juxtacanalicular trabecular meshwork, the major area of obstruction. Of course, you still have some obstruction with the distal outflow system, like the collector channels, but removing the trabecular meshwork can usually get you around that 12 to 13 millimeters of mercury. But divvying it up into high and low pressure gave us a little bit of an insight. If you were just looking at this side of the table here and you see the baseline of under 16.5, patients with a decrease of greater than 20%, only 15% in that case. And you would say, well, I'm not too excited about that. as opposed to the patients who came in with 16.5 or above. They had 100% of those patients that were followed have a 20% or higher decrease in pressure. But when we're talking about angle surgery in a lot of these patients who have lower baseline pressure, oftentimes our target is to get them off of some of their medication and not to have a very dramatic decrease in their pressure. So in this case, what we see is that their decrease in dependence on medication, 85% of these patients were able to go down one or more drops, even when they started at a lower pressure. And those patients who had a higher pressure still were able about half the time to get off at least one of their drops. So I think you have to look at the risk benefit and what you're trying to do with the different segment of patients, knowing that you're still going to get around 12 millimeters, 13 millimeters of mercury for a lot of the patients that you're treating. Now, I'm just going to talk about this slide briefly. We're starting to get much longer follow-up. This is a 30-month follow-up showing essentially what I just showed. So starting off at a pressure of around 19, getting to a pressure of around 13 millimeters of mercury with follow-up, and still having a significant decrease in medication. The only reason I'm showing this slide is to show that there is significant follow-up, and the most recent follow-up that we have is actually going out to 4 to 5 years, and we're still seeing in a significant amount of these patients that they're maintaining their decrease in intraocular pressure. Now, if you don't remember anything else about this talk, I want you to remember this slide. This slide to me is extremely important, and it was a study that was done by Cyril and some other colleagues. This one of the other centers was in Vietnam. And we started noticing here at the University of Colorado in the patients that we were doing that have angle closure, chronic angle closure glaucoma, that going in and doing goniosynechiolysis as well as removal of the trabecular meshwork with an excisional goniotomy almost always resulted in a very dramatic decrease in their intraocular pressure. This is where goniotomy should be the primary surgery of choice, in my opinion, before you do anything else. So even in very advanced cases, before you do a trabeculectomy or a glaucoma drainage device, you can see here that the response from a baseline of 25.5 down to 13 in these patients and a medication decrease from 2.3 down to 0.14. This is not unique to this study. It's published and we get to point at it and say, look at the data, but this is the same exact thing that I see in my practice. And certainly those who are doing a lot of goniotomy are seeing similar results. So if you have chronic angle closure glaucoma patients, I want you to think about doing a goniotomy along with goniosynechiolysis, and you'll see pretty dramatic decrease in pressure that is sustained for a long period of time. One of the studies that we get asked a lot about, the whole angle surgery, whether it's MIGS with implants or angle surgery without implants like goniotomy, we don't have a lot of head-to-head data. We're not able to say, okay, if you do iStent and then on the other side you do KDB, what are the outcomes? Early on, we did a retrospective analysis with multiple surgeons looking at iStent versus KDB. And we saw pretty good data on both sides with KDB showing more IOP lowering and decrease in medication, but it was retrospective. And of course, as glaucoma specialists, we're always asking for more data. We want to see head-to-head and we want to see prospective. So New World stepped up in this case, and they did a prospective study with multiple centers looking at KDB versus iStent and doing it in the patient population where iStent was studied. So this is the mild to moderate glaucoma patients who are combined with phacoemulsification, prospective randomized, and these were parallel groups that were done again in multiple centers. And the primary endpoint was a decrease in pressure of greater than 20%. Or a reduction of one medication or more. And the reason for doing it this way is if you look at the data for iStent, the approval data in the United States, one of the primary reasons why you saw the approval of the device is that even though it was about 1 millimeter of mercury lowering more than just standard cataract surgery, there was a lot of debate as to whether 1 millimeter of mercury was significant. You still got patients off of their drops, which was thought to be significant and one of the reasons why the device was approved. And I totally agree with that. I think getting patients off their medications is a great thing. When looking at the primary outcome, 93.7% of the KDB eyes met the primary outcome versus 83.3% of the iStent eyes. you can see the IOP lowering from a baseline around 18.5 to 16.1 and 15.4, 15.4 for KDB, 16.1 for iStent. And again, a reduction in medications that was significant for both groups. The percent of patients who had a pressure less than or equal to 18 was significant in favor of KDB. So this to me is one of the reasons why I don't do as many implants in the angle. I choose to do implant-free surgery like goniotomy with KDB. And it's good to have this kind of data to show that IOP lowering is as effective, if not greater. And in this case, this study shows greater, keeping in mind, of course, that we don't have 2, 3, 4-year follow-up on this, but I think this is indicative of how it performs in my hands as well. So overall, 24 to 36% IOP lowering, you see a significant decreased burden of medication use going out to 4 to 5 years now, significantly better compared to the TM bypass devices that the device has been studied against. And of course, demonstrating efficacy, safety, versatility. One of the things in the US that isn't the case in many countries around the world is that we can only use iStent and Hydrus when combined with cataract surgery. That's the way it's approved. You could certainly do it without cataract surgery, but the patient would have to pay out of pocket in that case. With devices that allow for implant-free approaches like KDB, you can do it on standalone, you can do it combined with cataract surgery, you can do it on mild glaucoma or advanced glaucoma. So there's a lot more versatility there compared to putting in an implant. So I'm going to finish off here with a couple of points that are important to me, and I wanted to convey one of the important aspects, at least for my practice. This started off in the laboratory, as I mentioned, because we were trying to do imaging devices and eventually went to the operating room. And what we found out when using KDB in the operating room is it actually gave us the capacity to then take things back to the laboratory. So it was kind of going full circle. And in this case, what I'm talking about is the fact that we're stripping trabecular meshwork in our patients allows us to then collect the tissue and to do further studies on that tissue that can help elucidate a little bit more about the disease. And this is my partner, Leo, showing a strip of trabecular meshwork. So we're not only collecting it here internally for our department, we're also partnering with different companies who want to look at trabecular meshwork for biomarkers, medication effect, discovery to see what different molecules could be targeted to influence the disease. And to me, this is extremely exciting. For the first time, we used to try and do this with trabeculectomy samples, and we almost never got trabecular meshwork with a punch. We usually got cornea, sclera, anything but trabecular meshwork. Now we can go in and get a strip of trabecular meshwork, and we do anterior segment OCT afterwards to see exactly how much of the leaflets are remaining. And it's typically like this. This is Nate Radcliffe who sent over this image, where we don't have a lot of remaining leaflets. So we know we're getting a significant amount of the trabecular meshwork. And now, like I hinted at earlier, we can do stains on the trabecular meshwork and figure out what the healing process is. So not just biomarkers, but what is happening from the standpoint of trabecular meshwork akin to what we might see with a glaucoma drainage device where we see encapsulation fibrosis. Does something similar happen in the trabecular meshwork? And this is a case that I did a couple of years ago where the iStent that I placed was moving out of the angle. So I went in, and as I was doing the goniotomy, you can see that there's a little bit of resistance, especially when I start going the other way to get the trabecular meshwork out. Right here, you can see, and I can see a film that's actually developing over this area where the iStent was. And I'll do a close-up shot here. You'll see this is the trabecular meshwork coming out, but there's this film that's in this area right over here that will be highlighted right there. So this is a fibrovascular bundle that was growing over the iStent that was sitting in this area and was actually moving the iStent down. That's why it was so easy to remove the iStent. And it got us thinking, like, what is actually happening with these devices that are sitting in the angle? So we collected a series of trabecular meshwork on patients who had a previous iStent placed in the angle. And we saw exactly the same thing for every sample that we took out. The trabecular meshwork cells were decreased. So this is normal pigmentation. And what we were seeing in all of the samples was a decrease in pigmentation. And then these are vascular bundles, basically, for the most part, fibrotic tissue, similar to what you might see with a ring of steel or encapsulation of a bleb. So the eye likes to become fibrotic and encapsulate areas of foreign body. And, you know, here's one eye, here's another eye. You see exactly the same thing over and over again. And I think this is one window into figuring out exactly what's happening when we leave a device in the angle. And again, one of the reasons why I don't like to leave devices behind, knowing, of course, that I'm biased in the way that I practice because of my experience with goniotomy. So I wanted to summarize here before getting to the question and answer session. Hopefully I was able to convey some of these. And again, I'm happy to discuss them in length. TM excision allows for access to multiple collector channels. My goal is to not just get one collector channel. If I can get 3 or 4, I'm very happy. I don't think I need 360. I think, you know, mathematically, if I can get 2 or 3 collector channels, I'm getting the pressure that I need, and I still have angle to operate on in the future if I need to. I don't like to leave foreign bodies behind if I don't need to. So I don't do very many implants right now in the trabecular meshwork. For the most part, I'll do a trabecular meshwork based excision and then move on to, if that fails, I'll move on to a bleb forming like a Zen, an Express, or a trabeculectomy before going on to a tube. And it spares the conjunctiva. So I always have that ability to go back and do something that's more invasive if needed. And that's why I still do severe and end stage patients. It can be performed in combination with cataract surgery or standalone, and it could be performed on a wide range. We even have a series that was done on quiescent, quiet uveitis eyes, where it showed efficacy. And of course, I've mentioned the chronic angle closure. And now we can say that it's backed by clinical data. I think at last count, there were at least 25 reports, most of them published on PubMed, that shows efficacy both in decrease in IOP as well as dependence on medications. And we also have prospective data now showing that it performs very well versus a TM bypass device. So all of this together, I think, is great evidence that even though the dogma used to be that you can't do goniotomy in adult, that it doesn't work long-term, I think we're way beyond that now. I think the truth is that we can do implant-free angle surgery, and I think it's a good service to our patients. So I'm going to stop there, and I'm going to open it up to any questions. I'm happy to answer, and thank you all for listening. I'm going to show this last slide here while we're doing question and answer, just to give you a couple of resources. Anybody can email me. I'm happy to answer this. That's the top line. And then there's some free educational resources at keogt.com. And then I post all of these talks and videos on YouTube, Twitter, and Instagram. I don't do social media, but I do post videos, and I love seeing everybody else's videos. So if you have anything to share, similar to what Fabio did when he sent me his episcleral venous wave, I loved seeing that. So anybody who has videos, please share it on these channels, and I'd love to see them. So thank you very much, and I'm happy to answer any questions.
So, Dr. Malik, thank you for your outstanding presentation. Would you please just stop sharing your screen? Yeah, that's great. So I had a question before, but probably you already answered. Regarding MIGs, we do not have the same MIGs that you have in the United States. So as you have most of them available in the world, would you see any indication for example, an eye stent, or instead of KDB or GAT?
So these are very difficult questions to answer because we don't have a lot of head-to-head data. So what I will say is that I'm a fan of all devices. I think that everybody should use what's best in their hands. Certainly I used iStent in the past. We did, I even went to Armenia to do some of the initial implants, and I think Glaukos has done really great work for glaucoma and for our patients. Yes. So no issue there. It's just in my hands, goniotomy works better, right? So I think that's the important point. A lot of it has to do with the surgeon and what they're comfortable with. And what I like to choose is something that would apply to all of my patients. Certainly there are contraindications to iStent. In the US, I can't use them on severe patients. I can't use them standalone, right? Because otherwise the patient has to pay from pocket. that's the answer for iStent. I think, a lot of the patients, you can use either KDB or iStent and you're probably going to be okay. KDB gives you more versatility where you can do a wider range of patients, in my opinion. Okay. GAT, on the other hand, there's a simple answer to that one. GAT has more complication. And even the people who pioneered GAT would tell you that there's a higher risk for hyphema. You're treating 360. I don't think you need 360 to get to the pressure that we want to get to with the majority of our patients. And because you're incising the trabecular meshwork and you're not excising, there's a tendency for fusion to happen. And a lot of times with GAT, it actually comes off at Schwalbe's line. So there's a big flap and those flaps can close. They don't always close. Oftentimes they don't, but they can. And a lot of patients that had GAT who come to me and I do gonioscopy, it looks like a normal angle. You can't really tell that anything was done because of the healing process. So that's how I think of things.
Okay.
Fabio, may I ask a question?
Yes, of course.
So, Dr. Malik, thank you for your presentation. It was an excellent presentation. The basic science part of it was, I didn't see it before, it was really good. I'm aware of most of your publications. And one thing that I missed in your talk, and regarding cost, I don't know how it works. I know a little bit how it works in the US, but here in Brazil, usually if you're planning to do like an iStent, the patient has to pay for it. And even if the insurance plan would pay for that, someone is paying, I mean, if the insurance plan will pay or in fact. So my question is, usually in medicine, cost is always an issue. So if you have two things that works, they have same results, same efficacy, the safety profile is not too much different. And at least in Brazil, I don't know how it works in the US, but here, an iStent costs like 6 or 8 times more than a KDB, like 10 times more than a GAT procedure with pulling.
Yeah.
So in your opinion, why, I usually like to know your opinion on cost effectiveness, I mean.
Yeah, this is a big question. It's a great question. And this was in Glaucoma Physician, there's an article by Andrew Iwa who just published it just recently. You can actually see it online at Glaucoma Physician, where he talks about his choices and why cost is a big deal. So I can give you prices in the US, right? And it sounds like it's pretty similar. So the iStent, for example, here in the US is going to cost somewhere between $1,200 and $1,800. Depending on your volume and where you are. And those are rough numbers, right? KDB is going to be, more on par of that 400 plus a little bit range, depending on where you are. To me, there are multiple things that come to play with the facility fee, and I'm sure it's probably similar with what you're dealing with. But there's a significant cost saving to our operating room that goes beyond just that number that I told you. For example, if we have 1 or 2 iStents that don't get paid by the insurances, some insurances don't cover, then you've lost a big chunk of money as the operating room. So you have to think about these ancillary things all the time. I try to pick what's best, of course, and then I work backwards to see if it's still financially viable for me to continue doing that. But there's another part here that I think is probably more important. As a company, New World will tell you that if you have patients who are not able to afford the device, that they're going to find a way for you to get your hands on that device for the patient. Since I've been working with the company, they've given thousands of free KDBs around the world for medical mission. And even here in town, if there's a patient who's unable to pay and a surgeon calls, oftentimes the CEO of the company will mail a free device to the surgeon in order to get it done. So they're very good about collaborating with surgeons and patients to make sure they can get devices for free or at cost or, for a discount when needed. Now, how that works, in Brazil and other parts of South America, it's going to be a little bit different because of import-export issues that go way beyond my brain. But cost is definitely something we should be considering. And implant-free procedures, whether it's GAT, KDB, or any of the other implant-free procedures, are going to be less expensive.
Thank you. I have the same opinion.
I saw that you took some time to take off to remove the membrane. So is that important? Because in my practice, sometimes I left it if there.
The trabecular meshwork?
Yes, I do not remove it. I mean, sometimes it comes to atrophy and disappear. So what's our feelings?
Yeah, so great point. And there is a technique for doing goniotomy that's called the inside out, where you go nasal and you do 2 clock hours to the left, 2 clock hours to the right, and you don't remove the trabecular meshwork. And I've done that. I have not run into any issues. The trabecular meshwork tends to curl on itself, sits in the angle, and it doesn't bother anybody. And I think that's definitely a viable option. If you're going to do a strip that's 3, 4, or 5 millimeters long, I would definitely not leave that tethered, because it can work its way to the corneal endothelium. And in some cases, it can work its way to the paracentesis or to the corneal wound, right? Depending on your placement. So if it's short and it's only a couple of clock hours, just leave it be. You don't need to take it out. Definitely, it just curls in place and it becomes a fibrotic ball, and it doesn't impede the outflow. But if it's longer, I would definitely take it out.
Mark?
Just one last question. Malik, I also do a standalone procedure, but in pseudophakic patients. I personally had a bad experience in one phakic patient that I did. And I would like to know your opinion on that. If you also do, in your standalone cases, if you consider phakic patients.
I don't like doing standalone in a phakic patient. If I'm in there, I'm taking the cataract out. The patients in my practice, they pretty much all have cataracts. If they didn't, most of them come to me pseudophakic, because cataract surgeons are, very good about taking the cataracts out. But if I'm in there, I'm taking that out because it's going to help the IOP too, right? So you might as well do that, get the benefit of the cataract extraction, do the KDB. I do a lot of standalone in pseudophakic patients. And I also combine in some cases with endolaser. So depending on what my target is, and I try and mix and match and do as much as I can with inflow and outflow. But I can tell you in pseudophakic patients, standalone KDB is still getting me to that pressure of around 13 or so, 13 and a half. So in pseudophakic patients, I think it's a great step before you do anything that's bleb based, any type of trab or a tube.
Dr. Malik, what is your experience with young patients or congenital glaucoma? Do you have any experience with this?
Yeah, so my partner here is Emily McCourt. She does a lot of the goniotomy procedures on our congenital pediatric cases. And there are publications on using KDB in congenital glaucoma. Albert Khoury from out of New Jersey has a couple of papers, at least one that is published now in the public realm. And what you see, the thing about congenital glaucoma is it behaves very differently, as you know. So if you put an incision in the trabecular meshwork, oftentimes there's a separation that takes place. And goniotomy with an MVR blade is frequently successful in those patients, very different than doing it in adult patients. What I like about, there are two things that I like about with KDB and congenital. One is if you're in an academic center, it gives you the chance to do histology research to see a little bit more about the disease process, which I think is extremely valuable. The other thing that KDB does is because it sits in the canal, it gives you more stability as you're doing the treatment. With an MVR blade or a needle, there's a tendency for it to move out of plane, especially if the surgeon isn't doing a lot of goniotomy procedures in kids. So it gives you that added comfort of less collateral damage, in my opinion, right? That's not something that has evidence-based medicine on it. But yeah, certainly there's data on it, works very well, just like goniotomy does in most congenital glaucoma patients.
You talked about it during the lecture, but your experience with gonociniacalysis in patients with uveitis, you do a gonociniacalysis and do the Kahook. It's a good experience. It's a good idea to try it.
Yeah, so I like goniosiniculitis. I find it very satisfying as a procedure. And there's been a little bit of debate recently. There's a paper that came out recently that said goniosiniculitis maybe doesn't add as much IOP lowering, but there's much more data to show that goniosiniculitis does add a lot. But when combining, especially in chronic angle closure, so not necessarily in quiet, non-recurrent uveitis, but in chronic angle closure, going in, doing the cataract, doing GSL, and then doing KDB has been one of the things that I can say is a home run, or I shouldn't say home run when I'm talking to people from South America, should I? Right? It's not. I'll say it's a goal, right? It's a.
Yes, better that.
Yeah. So in my opinion, it's an easy. You like that, right? It's an easy. I grew up playing soccer, so I get it. I think it's an easy one for me to tell the patient. I feel very comfortable that you're going to get significant IOP lowering, and we've proven that with studies as well as our own clinical practice. So I'd love to hear from others. You know, if you start doing more of those, please email me and let me know what you guys think.
Do you leave the patients on pillow, and if yes, for how long?
So yeah, another great question, because initially we thought that we needed to do that routinely because there was this, theory that you keep the angle a little bit more open with the TM. If you do have some leaflets left behind, you're deepening that space specifically by separating the tissue. And I can tell you very comfortably after years of doing the procedure, you don't need pilocarpine. Now, what I do is, while the patient is still on steroids after surgery, I keep them on one of their glaucoma medications. Typically here for me, it's latanoprost, right? And the reason I do that is you can still get steroid response glaucoma in angle surgery, as you all know. And sometimes it's more severe than what you see without MIGS procedures. So there's something there that allows the patient to just really spike in pressure. So I keep them on one of their drops, frequently a prostaglandin analog. After I take them off their steroids when they've been weaned, then I take them off of that glaucoma drop and I see where they end up and I start back drops as needed. But I don't routinely do, or I don't routinely recommend doing pilocarpine. We still use it from time to time, of course, but it's not necessary.
It seems that was a very good consequence of your basic science studies, huh?
Right. Every now and then.
Very interesting for us.
That's right. Yeah. And I can tell you we have a couple of other things coming in the next couple of years with, different outside of this space of angle glaucoma surgery, where I'm always surprised at how many things are sort of, by accident. You discover this thing and you're like, oh, this really works. So let's run with it.
Marcos, seems that Professor Remo want to ask a question. Would you?
Thank you.
Allow him.
Hey, how are you? It's good to see you.
Hi, Malik.
It's nice to see you. How are you?
I was hiding from you.
Good to see you.
Very nice to see you. So far, but so close.
Yes, that's right.
Okay, Malik, I have two questions. In reality, only one. But I don't think it's my impression that blanching of the conjunctival vessels are an indication of success, as we can see in viscocanalostomy. I'd like your comment on that. The second one is that with your procedure, you reduce the pressure to the level of episcleral venous pressure. Why not you use it also in severe glaucoma, in advanced glaucoma?
So two great questions. And I'll start off with the episcleral venous wave. The way that I see the wave is more important if I don't see the wave. When I don't see the wave, I'm worried that I'm not going to be successful. Not everybody who I see the wave in is successful, but almost everybody where I don't see the wave, most of them are not successful. So that's the way that I use it. And I think your point is well taken. And I learned a lot of this from Ron Feldman, who first introduced it at a meeting that I was at. And of course, Devinder Grover has done a lot of this work, and Ike Ahmed has done a lot of this work as well. And that's how I use it. So I learned and started using it in that way. Now, you asked a question about severe glaucoma. I routinely do goniotomy in severe and end stage. And we have multiple papers now showing that it is efficacious in patients who, I have a series that I haven't published yet, we're submitting it soon, on dozens of patients who we normally would go and do a trabeculectomy on them, where instead we did a KDB on them, we did goniotomy. And those patients, about 50 to 60% of them do extremely well, and they don't need a trabeculectomy for 2-3 years afterwards, maybe longer. We're still following those patients. So I still think you should consider doing angle surgery on severe and end-stage patients, with some exceptions, of course. But because of the way MIG's conversation started, it started with mild to moderate glaucoma combined with phacoemulsification. We kind of, we accepted that as the only way to do angle surgery. And I don't think that's the case. And certainly multiple papers, not just from me, but from others, showing that it works really well in severe and end stage. So great questions.
So
yeah, it's good to see you again. Yeah.
Malik,
Yes.
just one more question regarding the extent of the treatment. So in some meetings, we have this conversation, if more, a larger extension would be, would benefit more in regarding IOP reduction. So what's your opinion? What's your thoughts on that?
So I can tell you that in the laboratory, when looking at perfused eyes, perfused human eyes, anything over 4 clock hours doesn't add benefit from IOP lowering. If you're doing an excisional removal of the trabecular meshwork, you're not as worried about refusing of leaflets. 4 clock hours gives you just as good of a chance of getting a pressure of 13 to 14 as 6 clock hours or 8 clock hours might do. So I typically do 4 clock hours and no more than that. I think that we did have data years and years ago to show that 6 clock hours might be better than 4, might be better than 2. But we started off with laboratory studies to show that, okay, what's the sweet spot? And it turns out it's around 3 to 4 clock hours. Since then, of course, we've done hundreds of patients, and I can tell you that looking at 3 clock hours versus 6 clock hours, there isn't a difference. You're probably exposing 2 to 3 collector channels by just doing 2 clock hours. So as long as you're doing that, you're getting the same IOP lowering efficacy. And I'd rather treat what's in front of me than trying to get a little bit more without the added benefit. So I stop at 4 clock hours.
Thank you. Thank you.
I think that Alberto has a question.
Yeah. First of all, I would like to thank you for your time and presence here.
Thank you.
Malik's, I don't know if you guys here know, but he has been active in both basic and clinical research. He has more than 100 of patents. So, and it's a really honor for us. So I needed to change my cap. As the guy said, I was a New York one, but I'm from San Diego.
That's
the
great.
guy survived Bob Rich, and I survived Bob Wyram. So I would like a simple question, Malik. What would be the next step in MIGS? So what do you think?
Yeah, so great question. I think we're getting to a place right now where we have a really good understanding of what different materials do in the angle. We know how goniotomy performs, whether it's incisional or excisional. We're learning a lot more about procedures that inflate Schlemm's canal or canaloplasty type, ab interno canaloplasty type devices. And they all have utility. I think they all have benefit, and we should think about where they might fit into our patient care. The one piece of information that we still don't have, and it's something that Bob Weinreb has looked at extensively, is the healing response that happens in the angle. So can we look at different materials or different medications that will help with the mid to late term failure that we see sometimes in our patients because of the desmetization or the development of a film over the angle? We don't have a good solution for that. So whether it's a novel material, a coating of the material, we know iStent is heparin coated, for example, but routinely the iStents get covered by this film. So is there something better? I think that's going to be one big thing. And certainly we're looking at that and others are looking at it. The other piece is one of the things that Remo really, with his question, touched on, which is let's understand a little bit more about what's happening in the collector channels. And is there a way to address the collector channel blockage or the aqueous vein back pressure so that we're not just treating AC anterior chamber to Schlemm's canal, but Schlemm's canal to distal outflow system past the collector channels? We might have other ways of doing that beyond just putting a hole in the eye like a trabeculectomy. So I'm excited about the future. I think a lot of really smart people are working on it. We're trying our best as well. So I think we're going to see that next generation in coming years.
Great, thank you.
Yeah, thank you for that question.
Malik, another question. It's here on the chat. Sorry, Thiago.
Yeah,
Dr. Eloise is asking you which one was the most the bigger complication you had with doing the Kahook?
Yeah, so I got this question. I was on another webinar and there was a question that came about this. And what I always like to say is there's no free lunch with glaucoma surgery, right? If you do enough glaucoma surgery, you're going to see complications. If you have a procedure where somebody is telling you there are no complications, then you should say, okay, there's probably no efficacy, right? You're not going to get it for free. So with any type of implant or KDB or GAT or anything that we do, the most common thing that we see is bleeding, right? And fortunately, it's not very common where we're seeing it in a high proportion of patients, but we do see it from time to time because we're going through trabecular meshwork. I think that's probably the one that comes to mind as the most significant. I've had a couple of patients who have had significant heme where it stays in my mind. It's something that you remember. Now, there are steps that you can take to decrease the chance of that happening. And I just want to say a couple of words about that. At the end of a procedure where you've done a goniotomy, if you inflate the eye with balanced salt solution to a pressure of around 25 millimeters of mercury, and you hydrate the wounds, the chance of you having a hyphema post-op day 1 go down dramatically. The other thing that I do routinely is I leave a little bit of dispersive viscoelastic in the angle at the end of a procedure. And it's basically a 10% fill. So just go into the angle, leave a little bit over the iris. Once you see the viscoelastic, that's about 10% if it's 4 o'clock hours. And that has almost eliminated the microhyphemas that you could see post-angle procedure. So there are things you can do to decrease the chance, but certainly with surgery, you're going to have complications, and that's certainly one of them.
Malik, quick question. Have you done goniopuncture with YAG laser in late failures? I've done 2 times. In just 2 cases, I had good results. In cases in which the initial IOP reduction was impressive, and like 6 to 8 months later, stopped working. Right. And I did a goniopuncture with YAG laser.
Yeah, so I have done that in the past, in the distant past, when using other devices, and I found that it didn't last very long. So you sometimes get a very dramatic decrease in pressure because certainly you've punctured through, but 3, 4, 5 months down the road, it usually, in my experience at least, the pressure goes back up. It has to be a YAG laser to use. You can't use thermal. It has to be disruptive because it's not pigmented most of the time. So you really want that concussive power. But even with significant YAG and doing multiple punctures, it tends to grow back. It's kind of like when you put a plate under Tenon's capsule, it wants to fibrose. The eye is stronger than we are. It always wants to make us fail, right? So even in the angle, it has ways of doing that. And that touches back on the question. I think it was Alberta that was asking where I answered about the that next phase of healing and how to deal with that. So we're not quite there yet. We have to get smarter.
Thank you.
Okay, people, any more questions? So thank you, Dr. Malik, for your time. You really brought new statements for us. I think that most of the questions were very well answered. So thank you for your time, your presentation, and welcome back.
Yeah, I'll tell you guys, thank you so much for having me. Please email me with any questions. We learn from each other. So I love the exchange that happens. And I hope everybody stays safe and that the next time we're at a meeting, if we see each other, we can give each other a big hug without sanitizing our hands or anything. A big hug.
Thank you. Thank you so much. Bye-bye,
All right, guys.
everybody.
Have a good one. All right.
You
Bye-bye.
too. Bye-bye.
Bye.
Thank you.
Yep, bye-bye.
Thank you.